Hey, Joanne.
Hi, Michelle. How are you?
Good.
I'm excited to be here.
I know we've been planning, we talked about this before COVID, and then we kind of got off track with COVID.
COVID, right. And I'm like, sadly, we have our medical team meeting once a month, and it's the third Wednesday of the month. And I'm like, but this month I just said, sorry, this is what's happening. So anyway, it is what it is, you know.
Yeah, I have a lot of people who have their meetings just by chance it's the same day. And the positive is now that we do record them, and so that people can go back. And I've talked to like new hires and said, hey, go back and look at some of this stuff. It's sorry, I can't talk at the same time. Let's see, let me go back. You know, it's hard to get. And then again, we've had some great presentations from staff, and you're like, let's you know, it's great that we can share them. Okay, let's try this again. I can share. And do you have slides, Joanne?
Yes, I do. And I think I was way over ambitious, but we'll just go with it.
Yeah, I mean, we'll run through, and then what we'll do is we'll have staff, and even if we go over, we can go over a little bit, and people have to go back to, you know, their things. They can do that, and then they can watch it, the rest of it later. So that's totally fine.
Yeah.
And I'm just going to run through my slides just to give a quick, like 5 minutes, and then we'll give you the rest of the time.
Great.
And we'll try to start as close to on time as we can. We'll try 1201, 1202. All right, we better get started because we have a lot of stuff to kind of go over as people check in. Welcome everybody to the May Brown Bag. Today we're just going to go over a few quick things, and then Joanne has a presentation for us, and we'll just kind of I want to give her as much time as possible. And so, well, this is our agenda for today, and we'll just kind of keep going. Lots of new hires. lots of pending hires. We're moving along just fine. If any of your coworkers are not getting the calendar invites or on our listserv, just reach out and let me know. We had Dana and Bong start recently. And I believe we had Megan Darrow start in the April-May timeline. And we have a few that are going to start soon. So it's great. I wanted to say congratulations to Violet Robb. She finished her DNP. It's a big deal, a time commitment. And then I had just gotten some recent feedback from her department, from patients. And so again, she's a great resource, very professional, which of course is our typical APP at Harborview. And then all these CARES Award nominations. Of the 4 providers nominated, 3 were APPs. That's pretty awesome. Jamie, Elise, and Audrey all were nominated, and then Jamie was nominated for team, and so was neurosurgery. So congratulations, everyone. And remember, nominations are accepted all year. Just because a deadline is a certain time, if you're like, finally have some time and you're like, you know what, I want to talk about somebody, and I'm happy to help as well. So just reach out. And so, yeah, because it's a great honor to be nominated here. Just a reminder for student placements that if it's an outpatient, please reach out to me, and inpatient is Jenny. If students are reaching out to you, please refer them back to us. We kind of started a policy just because we've had some issues in the past. We've had students who didn't have a clinical coordinator, and there was some issues, and we couldn't find anybody to talk to them about. So we've decided that unless it's a clinical coordinator reaching out to us, we're really not going to accept those students. And then we are trying to limit the amount of increased affiliations. We have quite a few affiliations with like Gonzaga, SU, SPU, UW, Georgetown, George Washington, and multiple others already. This last quarter generated about 60 emails for me, people requesting students coming from all areas, and quite a bit of you reached out after I asked for placements, and we were able to disperse quite a bit. And I like doing it that way just because I think it helps be more equitable when we're just sending them out kind of just evenly distributed versus someone coming to me and say, hey, I'm taking a student that's a friend or family or a friend of a family. And it just seems a little more equitable this way. And then plus, we don't want you guys bombarded. I'm getting bombarded. I'm sure some of you have been too. And so the more you guys say, hey, reach out to our leadership, it helps decrease those people coming out to you. Chronos, again, the reminder to check your time cards, approve them. That helps decrease the errors. There's quite a few time cards that have to be reviewed in a very short time. So missed punches and those things, it's great if you guys can help us with those. It is part of now kind of performance evaluations as well, because it's such an important thing to make sure that you're being paid correctly and it's less errors and those kinds of things. Self-evaluations, make sure you have your self-evaluation done by May 31st and that you have requested 4 or 5 references to include your supervising physicians and attendings you work closely with. Do 4 or 5. The reason is sometimes we don't get them back, and we really want to have as much input because you guys did such great work. Let's get all that information into your performance evaluations, and be sure to include comments for distinguished or needs improvement, just because we want to know what that issue is. We are going to start doing those performance evaluations early. We have a lot to do, and we only have a couple of months, and your guys' schedules really are hard to kind of get everybody in a timely manner. So we want that done as we want to start early. Open positions, quite a few of these are in the process of potentially offering positions, but this is so far what we have. We have quite a bit. So if you have friends that are interested, please reach out. I put this last year, or the last brown bag, just to remind you that Harborview is changing. When we first started the bond, they were not going to increase the bed count. They felt like, oh, just changing to single room would be enough. But as you've seen how full we've been, they're going to increase their license 100 beds. This is almost a $2 billion project with changes in behavioral health services. Respite is getting expanded. there's just a lot of things that we've needed that I think you guys have helped, bring out that are necessary for us. But this is a 10-year process, so some things will be sooner than later. The mailing process is a 1 to 2 year process, and that's going to increase our beds, I think 30 to 40 beds, which is going to be helpful as well. I appreciate your guys' patience. I know a lot of you are being moved from offices to different departments to different buildings, so we appreciate your flexibility with that. But this is, I think, a picture of this, a much bigger picture of what it's potentially going to look like. You can see the pad down here where we are now, and then this huge building that we're going to partake in soon. The annual compliances started in March. It was giving a little more extended time. For the most part, it'll be due September. Again, get these done. I mean, a lot of the information actually is very useful. We know it's a pain in the butt to get it all done, but I tell people take, maybe do a little bit every day. It doesn't have to be done all at once. Just it needs to be done before, because we usually want it done before the deadline, because leadership does reach out to us saying, hey, your staff hasn't done this, so we have to reach out to you, and it's a little bit time consuming. And so we want to make sure we can get that. Boosters for 5 to 12 have been approved. We are not doing them yet, but just FYI, so that you know that's coming down the pike, because you may get asked about that. For equity, diversity, inclusion, it is Asian American Heritage Month. And I just pulled up from our website that 23.3 of our employees are Asian and 1.4 are Native Hawaiian or Pacific Islander. And then people of Asian ancestry are 9.6 people in Washington and 16.3 in Seattle. It's quite a bit. The onboarding task force met for the first time. Dr. Goss was also involved. The APPs that were present are listed, and they gave some great information and feedback. I know there's a lot of you that are behind the scenes giving feedback. I love it. This was one of my passion projects. I am big on the onboarding and the changes. So please feel free to reach out, but we have started those monthly meetings, and everyone is committed to improving this process for you all. Again, CME deadlines. June 15th is a deadline. If you're getting really close to the deadline, you want to go to your manager, hand it to them for a signature. We had a few people that sent it to their managers, and their managers ended up being out or sick, and they missed the deadline. And so if you're getting so close, you want to make sure that you have it in your hand signed, because you don't want to lose the CME. You don't want, there's $2,200 that you're throwing away if it's not done. And then the 64 hours also have to be used up. At this point, if you haven't requested the time off, it's really going to be up to managers to do any approval if they can. Sometimes it just isn't capable, because we do not want to cancel patients at this point. If you have questions, please reach out. And I just wanted to give some information. I didn't realize this, but some of you have reached out saying you haven't gotten your CME back, but there's a special email at the bottom here that tells you if you haven't hasn't been given, you haven't been reimbursed. This is where you send questions. I think we were all sending questions back to the original, the CREG, which we don't want to do. So again, here's another number, and then just some basic information that really is very useful about making sure it's filled out. Making sure there's reimbursement and how it happens and all those kinds of things. So take some time to read this information. Also, some of these things I didn't know, like if you're a presenter, you can use CME hours, prepping, all these things are part of your CME money. This is through PD&E's rules, which we like to follow. There may be some changes with us. We may allow for some more leeway on some of these things because we're a little different and have more hours than the nurses. But like even studying for your boards, you can take the day before, you can take the day of to study and then take that national certification. And again, if there's specific things that you have questions about, please reach out. All right. I'm super excited about this because I met with Joanne. Joanne's been around Harborview a long time, and she'll give you a little bit of information about herself. This is a big part of Harborview. Again, the crime victims, sexual assault. She's been involved with this for a long time. So I'd like to give her the floor to kind of go over, and I'm going to stop my share so she can share.
All right, let's see. All right, here we go. All right. Let's see if I can, hopefully folks can see that. I think
Perfect.
I would be a master at this given where we are in time. Oh, well. So again, I'm Joanne Mettler. I'm a nurse practitioner at the Harborview Abuse and Trauma Center. And I'm really pleased to be here. Hope that this is going to be what you're looking for. If not, I'm certainly willing to come back or whatever to make you successful or understand the material. And I've been over at the Harborview Abuse and Trauma Center now going on 24 years. So it's been a while. Again, I'm glad to be here. So I'm just going to roll. I have a lot of slides. I probably am over slides, but we'll just keep rolling and see what happens. So what I was hoping to accomplish today was to try to understand, who, what, when, where, why regarding pediatric patients seen for concerns of sexual abuse, look at what acute visits are versus non-acute, what happens during an exam, medical exam findings. And I did put some photos in. Again, I can breeze through those, not do those, whatever, just jump up and let me know. Understand medical findings. I'll touch briefly on STIs, key points regarding physical abuse. Again, I have like 3 slides on that. And I just want to also mention strangulation exams that are now happening in the emergency room. So as far as when to refer for an acute exam, if the incident was at 120 hours or less, and that's when a person should go to the emergency room to get a kit collected. And we're looking at things like saliva, semen, debris, like skin cells. We have touch DNA now. Things have really come a long way. We also look at toxicology, blood and urine, of course, testing for sexually transmitted infections, treatment, and pregnancy prevention, again, depending on the age. If patients are having pain, bleeding, discharge, and there's concerns for sexual abuse, certainly, again, that would be reason for an acute exam. High risk situation, if there's an abduction, multi-victim cases, unlawful depiction of minors, again, that would probably put it at the level of an acute or urgent exam. And then again, we've just added strangulation to that acute visit time frame. So as far as DNA is concerned, when's the best time? And clearly in kids, the research that we have is not a lot. But what we do know is less than 24 hours in prepubertal children is always the best. Of course, if the patient hasn't bathed or changed clothes, again, great time. Not always the case. Eaten, again, not always the case, but still better. And collect what they were wearing. And I would point to paper evidence bags, because if some folks don't know, if you put it in a plastic bag, you could be destroying evidence because it will not be good for that evidence if it's in plastic. And then bedding at the scene, and that would probably be in relation to the police going out to the scene. I've listed a couple of websites. Certainly I can share the slides in the sense that maybe I'll just, if you want, Michelle, I can share the just as a handout so people have that. But WASAFE, the kit collection video is really great if you want to learn more about that. We did that in our own clinic, and there's a great video about IM evidence. So where do patients get an acute exam? So if you're 14 and younger, Harborview Medical Center or Seattle Children's, those are pretty much the 2 places that folks should be directed to. If you're an adult or teen, 15 and over, there's quite a few listed there, as you can see. But I would definitely make note of, where you should send the children and younger teens. As far as who conducts a sexual assault or abuse exam, for pediatric exams, both acute and non-acute, myself, obviously, physician. And then I'll mention that for acute exams, like in our emergency room, for example, there's a physician, usually a pediatric resident, and a SANE nurse, and they work together as a team to collect that evidence. Acute adult and teen exams happen with a sexual assault nurse examiner, and that's for patients 15 and older. But essentially, any one of you or any of these folks, as I noted there, can collect a kit. If you want to pull up our guidelines, it does go through step-by-step how to do that. It's a long process, but it can happen in that way. If you're out in Podunk, the guidelines are there. So when to refer for a non-acute exam or that greater than 120 hours, and I would say, there's no urgent symptoms or the patient or parent are concerned. It's not a medical emergency, but always should be offered. And it should be offered sooner than later, especially in regards to kids, because there's lots of folks that often talk to kids when this has happened, their memories fade. So it's always better sooner than later. And I would say refer to an expert in the field because that minimizes the need to have yet another exam. And it happens at a scheduled appointment at our center, the Harborview Abuse and Trauma Center, which is like a doctor's office setting. And I'll show you a couple of photos, and any one of you are welcome to come on over and I can give you a little tour. But in general, folks are always feeling too that, they need to have this exam right away because they want to see if it really happened. And I'll speak in a few minutes about the exam findings, or essentially lack of. So that's not the biggest indicator of what happened or didn't happen, but most people don't really know that. So during an exam, and this is both in the ED and in clinic, the caregiver, whoever brought the patient in, we do a history from the patient, and both of those are done separately. And I'm happy to answer more questions about how can we do it in that way. We do a complete physical exam, including a good skin exam. And the skin exam piece is because of concerns regarding physical abuse. That's one of the first indicator that there's physical abuse because there's some mark on the body. In clinic, we use a colposcope. In the emergency room, we use a camera to document the genital and anal exam, testing and treatment, external visualization on patients. Essentially, next to never use a speculum, and I don't use the word never very often, unless, and this is really more in adolescents or adults, there's a lot of bleeding and we can't figure out the source, then we would go ahead and use a speculum. Collect a kit if it's indicated. Again, mostly that's in the emergency room. Any injuries, things that are noted on the body, they're either photographed with a camera, and again, in clinic, use a colposcope. Sedation is really required, next to never. Distraction in kids, of course, is always better. Referral to counseling as desired and indicated. As far as exam findings are concerned, as you can see there, most patients who've been sexually abused will have normal exams almost all of the time. Again, almost all of the time. Folks, whether they're kids, teens, adults, have normal genital anal exams almost all of the time. And so this also includes, as you can see there, patients that report vaginal anal penetration. And there's some classic articles there. You can see one that goes as far back as 1994. That all show that essentially less than 5% of the time, less than 5% of the time we have findings. So most of the patients have no findings. As far as bleeding is concerned, certainly if there's a report of bleeding, that's a big red flag that we should really be looking for injury. There's a lot of folks that think that this is going to cause a problem for them down the road as far as reproductive things. You all probably know that that's not the case, but I just thought I'd mention it. And again, just to kind of narrow in on the normal to be normal, most cases, and the data is probably even higher here, as I just mentioned, have no physical findings and have normal exams, including those that had a report of penetration. And I will mention that there are a lot of folks that don't know these things, that overcall things, that see things and they're not quite like, oh, and so they might jump to conclusion or say abnormal, which can be problematic if you think about the fact that these are also legal cases. There's law enforcement involved, CPS, prosecutors. So if you're going to say something's abnormal, we should have a second set of eyes, and that's how we do things in clinic because of the ramifications of what abnormal could mean from a legal prosecutor's perspective. And if we do just look at, someone wants to say, well, you know, we're just going to go on the exam, which of course, as you're probably getting the theme, we shouldn't, then most cases aren't even going to be identified. So for us, history is so key. All right. So why are exams normal? So maybe the abuse that happened doesn't cause any physical damage. Maybe that perception of penetration is error. You know, like a kid says he put his pee-pee in my pee-pee. Well, what does that mean to a 7-year-old kid? Do they even understand, you know, what in is? Reports are delayed often, years, months, maybe never in some cases. Complete healing can occur. There's anatomy changes that happen. So it may not be that you could even identify those injuries that might have been there. And if there was an injury, there may be, and most likely are, no physical scars. And I have a case that I can show you of that, that I saw in clinic. There's also those misperceptions out there, and I deal with this every day when I see patients, and I talk to mostly moms, but and I'll talk to other providers, and definitely CPS, law enforcement, prosecutors, and they all have these misperceptions about, you know, when there's penetration, that the hymen breaks, or the ring, or the cherry. All those misperceptions are out there that just not true. It's definitely a misperception. And there's some classic studies like Nancy Kellogg, who I noted here, saw 36. These were actually teens that became pregnant as a result of a sexual assault, but only 2 of them had any definitive findings on the exam. And even children with documented STIs, and we probably see a half a dozen of those a year in clinic, still have no definitive evidence of penetration. And then Carol Jenny, who's world known in this field, wrote textbooks and articles, documented all females are born with hymens. So, you know, now you might be saying, okay, Joanne, exams are normal all the time. So why do you even do them? Why do you even exist over there? And I would say, number one, and first and foremost, is that parents and children have lots of questions about their body after this happens, that misunderstanding that parents may have, kids have. So letting them know that their body is okay, even though this happened. I run into that probably every day. And certainly I want to document the ones that did have findings, help explain those normal exams are still consistent with sexual abuse. Just because I'm saying your child has a normal exam, that doesn't mean that this didn't happen. We certainly believe kids. Why would they even begin to make this up? So trying to help educate folks. Screen for STIs, of course, as you probably all know, some don't even have symptoms. And then have an opportunity to talk about counseling services. Gonorrhea and chlamydia, again, I'm just going to kind of breeze through these things because you may all well know these things, but we do test for that. And there are some cases, of course, you know, in little ones where they can still have gotten it from their moms. They might not show symptoms, especially chlamydia. We've seen a few cases where a child got gonorrhea and we think it was in relation to a household contact. May never know. The one case I'm thinking of was a toddler, so they couldn't tell us about what happened. But again, if the kid has an STI, we will see them, we will have a conversation with them. I have another case where we had 4 siblings that had gonorrhea, and all of them said nothing happened. And so we're left with, I don't know. So warts and herpes, again, these cause confusion for folks, especially like law enforcement, prosecutors, CPS, they might already jump to conclusions about it was sexually transmitted, but as you may know, that's not always the case and may not be the case. There's other things that cause confusion for folks about sexual abuse, straddle injuries, urinary tract infections, hygiene issues. I see that all the time. Yeast infections. I have a couple cases of foreign bodies. I can even show you one. Fissures, tags, and lichen sclerosis is classic for causing confusion in sexual abuse cases. Seen many of those. So this is what our clinic consult room looks like over in clinic, where we have an opportunity to talk with a parent or guardian and then talk to the child. And you can probably see, hopefully, my cursor down here. There's a little table where we sit and talk to the children. We do have a two-way mirror here because prior to COVID, we had a lot of pediatric residents regularly, as well as other residents and fellows who would train with us, and they would sit behind this two-way mirror, and there's a speaker here. And so they would participate in the initial history with the parent, and then during the child portion, oftentimes they would be in this room. Sometimes felt awkward to have a child, and then here's another person kind of sitting there while we're talking about some sensitive material. So this is our exam room, and as you can see, the colposcope is here, and I have a little bigger picture on my next slide. And then here's a monitor that projects what's seen through the colposcope. And the kids, honestly, I can tell you almost 100% of the time do so well in this exam. We have an old-fashioned Viewmaster that we use. The kids do great. It's often the parents that have the most challenging time, but if you set the stage of what their role is, it goes really smoothly, and inside of 10 minutes, you have an exam done. Here's the colposcope. It just, as you may know, magnifies things, never touches the child's body. Oh, I should, before I jump into photos, again, happy to answer questions, but I do have a bunch of photos. I thought maybe it might be a refresher or just an opportunity to talk about exam findings, if that works. Is that okay?
We have plenty of time. We're at 12:30, so we still have another 30 minutes.
Great. I feel like I'm moving at warp 9, but I kind of have a lot of slides. Get over ambitious. Anyway, so just as a quick refresher, and when I do an exam, I always start up here towards the abdomen, and I just kind of look at things top to bottom before I even touch the patient. And then these are the things that I look at during my genital and anal exam. The clitoris, the clitoral hood, the labia majora, minora, which of course is not fully developed in prepubertal children. I look for the urethral opening. The hymen, that tissue that sits in front of the opening to the vagina. Again, that's the tissue where people think, once there's penetration, it pops, it goes away. And then, of course, this is the opening into the vagina, which again, just for education purposes, most people think, like when I go to court and testify, I oftentimes will pick up a paper cup, like in this regard. And, I try to explain to people that the hymen is not this tissue that sits in front of the opening to the vagina. And when you have sex for the first time, it pops and goes away. It oftentimes you can actually see into the vagina, and after penetration or sex, there's still hymenal tissue there all the time, well into adult life, even after you've had many children, lots of sexual intercourse. So fossa navicularis, posterior fourchette, and of course the anus for the bottom. And then for us, when we're looking for injury, we're always looking in this posterior hymenal rim area, anywhere, and I'll show you how we document this, at what we call the 4 o'clock area through to the 8 o'clock area. Anything on a genital exam, it's routine to document based on a clock, and I'll show you some photos about that. So here's just another diagram of the things that we look at and document about. So obviously this is a live patient, a prepubertal patient. Again, labia minora not fully developed. The urethra here again is the hymen, the opening to the vagina, fossa navicularis, and the fourchette. And I would say this is pretty much what a typical prepubertal child looks like. Here's I made reference to a clock. Everything universal in my work is we always document everything by a clock, whether it's on the labia majora, the minora, the anus. We always talk about this clock. So it's classic in supine position. You know, the top is 12. Obviously, you can see 6 and then 3. And then we look for injury. If we're going to see injury, it's again anywhere in this 4 o'clock position around over to about 8 o'clock. Here's another case, you know, this is again a prepubertal child, labia minora, clitoral hood's up here. This is the urethra. Here's the hymen, and here's the opening to the vagina. And one might think, wow, Joanne, you know, that's a pretty big opening. Oh my gosh, something must have happened. And in actuality, I don't know. I mean, I didn't see this child before the alleged event. I can just say, you know, this child has a you know, hymen that's concentric in shape. It attaches up here around 1 o'clock. It's got a smooth edge. There's no disruption to the border of the hymen, and it attaches up here at 11 o'clock. So I'm going to call that a normal exam. And even though years back when I first started this work, we measured how much hymen was here, what the opening was, we've now learned that's not the way things should run. So we don't do that anymore. And here's another prepubertal child, similar, you know, here's all the hymenal tissue opening to the vagina, the urethra is up here, labia minora, very normal exam. And then when we move into adolescence or puberty, again, the biggest change besides the labia minora growing, the pubertal hair, we have the hymen that becomes this redundant, thicker, paler pink tissue. And it's very hard, as you can see from this picture, to even see into the vagina, and hard to even assess, you know, here's the edges here in this prepubertal child. We can see there's no disruption there, but it's challenging here, and we often don't even try to do that. So here's a close-up of a redundant, paler pink estrogenized hymen. So here's a couple cases that I have. You know, this is a child, and hopefully you can now maybe appreciate that, you know, this is all hymenal tissue. All of this is hymenal tissue in this prepubertal child, and you probably can notice that there's something here, and you're probably on track to say, Joanne, that looks like some kind of foreign body. And that is indeed what it is. It's toilet paper. And this is an 8-year-old little girl who went about 3 weeks with bleeding. And no one could quite figure out what the source of bleeding was. And so finally I saw her in clinic after she ended up in the emergency room at Children's. And then I figured out that she had this toilet paper, and we did a lot of irrigating and got rid of the toilet paper. And she was the sweetest, best patient. And her mom had her wearing pads because they thought that she'd started her periods early. And she was so excited that she probably wouldn't have to wear that padding thing anymore, because we definitely fixed her problem. And so that was a great success case, and no concern of sexual abuse. Here's a case where I mentioned gets confused often, and many of you might recognize this or not, of lichen sclerosis. And again, in lichen sclerosis, it's usually that autoimmune disease that we see in elderly, but we do see it in kids. And it usually has this paler, if you can appreciate this on my slide, paler like figure 8, where it comes over the labia, it spares the perineum, and then we see it around the bottom. And then we start to see this submucosal hemorrhaging. I think I have one more slide. In this case of mine, this little 4-year-old had pretty darn significant. This is probably one of the worst lichen sclerosis cases I've ever seen. And everybody thought she's in foster care. She had a complicated social history, that because she was allegedly abused, she must be self-mutilating and she can't be left alone because she's causing all of this. Well, indeed, one of the first things I hear about with lichen sclerosis, at least in kids, is itching. And so for her, I believe all of this was her self-mutilating behavior was because she was itching. And the blood underneath her fingernails was because she was itching, and all this submucosal hemorrhaging was causing problem for her, and bleeding. So the great news was, I'm not sure if she was abused when she was 2 and 3, but this was a medical problem and we could fix that. So that was a good thing. And, we do see adhesions, and then we do see adhesions. And as you can see here, maybe there's a little bit of bleeding. Learn from my mistakes that if you separate labia too forcefully, you yourself, or in my case, until I learned, can cause that tear. And then you have the bleeding. And if you don't even recognize that you caused that, then there's more people like, oh my gosh, she has bleeding. And so there you go. This is typical straddle injury. So it's almost like a crush injury where, child maybe fell onto the monkey bars, pulled this labia minora here, and actually caused this tear. Similarly over here, and there's actually a little bit over here. So that would be classic straddle injury, as is this. This is definitely a classic straddle injury. I have a little girl who was seen in the emergency room. And, the key thing about straddle injuries is it's usually unilateral, so one-sided, and is really all external. Like there's no injury beyond the labia. Certainly she's got a lot of significant injury here, but it's a great photo documentation of the straddle injury. This was a case I mentioned earlier, that healing happens. So this is a case of mine I actually went to court on, and we actually showed these photos, which is a little, still to this day, a little, it's not really the right thing to do, but it went well. And the jury are always polled after the trial, and they thought it was fine, but I still felt kind of like, so this was my initial exam 5 days after her alleged assault by her father. And she, and these are the cropped photos for the case. So I just left them as such in court. And so this is her fossa navicularis area. And you can appreciate hopefully this redness. And I was like, wow, it doesn't have any acute bleeding, but it looks unusual. We can have cases of what we call failure of midline fusion. And I was like, but that really doesn't look like that. So I said to her, I think overall you look great, but you have a little redness. It'd be great for me to see you back. So I saw her back, and here's her exam almost a month later. And had I not seen this initial exam, looking at her here, I would never know that she had this acute injury. So again, things heal. Similarly to almost like the inside of your mouth, doesn't leave any scars. This is actually failure midline fusion. And there's been cases, I had to testify as an expert witness about a case where they called this an acute injury when indeed it wasn't. And for me, like if I see this like that last case, and I'm like, is that failure midline fusion or what is that? I would just consider bringing the patient back. And if it's there, then clearly it's failure midline fusion. But it can cause confusion. Like, what is that? Looks a lot redder. And here's another case of failure midline fusion. This is normal anal venous congestion. But again, it can cause people to become alarmed, like if you've had worries, that something might have been happening, or you just have your own abuse history. And then all of a sudden you're cleaning your child's bottom and you wipe away and you wipe away. And all of a sudden you see this purple and you think this is bruising. And I don't know, your child just came back from visiting with dad, and maybe that's not such a great situation. And then, you kind of have this almost like step-like fashion, and you get to this point where like, oh, look at that, that looks like bruising. They can become concerned, and understandably so sometimes. Strep, this is a case of mine that I saw, that the kid had strep, which again can look that fire engine red, but thankfully in this child, the mom was pleased as punch to learn that her kid had strep, and I wasn't on the page of abuse. Now again, I could never say that definitively, but that's what that was. Warts, we get cases referred to us all the time because of warts, because again, people think that now the child's been abused. So kind of in summary, all pediatric patients with concerns for sexual abuse should be referred for an exam. As far as timing is concerned, again, 120 hours should go to the emergency room. Greater than 120 hours should come to our clinic. The exam is not traumatic. Don't use a speculum. Again, in our clinic, it's myself and other physicians that see the kids and adolescents, and then there's sexual assault nurse examiners that do the exams in the emergency room. And then acute exams, again, happen for kids at Harborview and at Seattle Children's, and then non-acute at the Harborview Abuse and Trauma Center. And the why, again, to identify the injuries, collect evidence if they're in the emergency room and needed, let parents and kids know, hey, your body's okay, STI testing and treatment as indicated, and then referrals for therapy. And I should mention that at HATC, the Harborview Abuse and Trauma Center, I try to describe it as, two clinics, I guess. One side of the clinic is the medical side, where we have our medical providers and we have a medical social worker that sees patients with us simultaneously. It's a joint appointment is the way I look at it. It's a two-part appointment. Part is the medical, what I do, and the other part is our social worker who talks with families. We administer some trauma measures, and the social worker discusses that with families. And the other part of our clinic is therapists who provide trauma-focused cognitive behavioral therapy. So let me check where we are time-wise. I think we're doing okay. Do folks have questions about sexual abuse before I jump a few minutes into physical abuse? Grab the water. I'm going to take that as a no and move on. So as far as physical abuse is concerned, I just want to touch on this for a second or a couple minutes and throw out some key points about, first off, as far as bruises concerning for abuse, those that don't cruise rarely bruise. Classic study by Naomi Sugar, who was our medical director for a long time, fabulous person and provider. Any bruises on infants less than 6 months of age are non-ambulatory, obviously huge red flags. Bruises in unusual locations, the ear pinna can often be seen with a slap. Genital bruising obviously is very concerning, except in those cases where there may be the straddle injury, but again, we're talking about littler kids, infants to up to 2 years of age. Neck and under the chin, anywhere on the torso and the buttocks, flexural bruises, pattern bruises, of course, loop marks, and handprints. And I'll show you a couple of quick little photos. And then, of course, there's bruising in medically complex children, which can be concerning for a lot of reasons, but it's also hard to get a history, as it would be in infants. And then there's the 10-4 bruising clinical decision rule that's been well studied, and I'll show that to you, which has to do with any bruise in a child less than 4 months of age, or bruising in the TENS region torso, ears, neck, which also includes the chest, abdomen, and the back, buttocks, GU, and hip. And again, the back on the spine is okay because that's a bony prominence, and no confirmed accident, like in a public setting, that accounts for the bruising in the TENS regions or infants less than 4 months of age. So those would be all things to like huge red flags. Probably might need to go direct to the emergency room, probably at Children's. So here's the TENS faces. So frenulum, again, if we see any kind of bleeding from the mouth, clearly the place to look is the lower frenulum or the upper frenulum. And we've seen many of those cases where that's been torn, possibly from, a bottle being shoved into the mouth, or maybe a pacifier, something forceful that caused that to tear. And then of course it bleeds easily and then will heal fairly quickly. The angle of the jaw, again, both of these cases in the cheek and the jaw are from slaps. And if you don't already know this, what happens is when the child is hit, the blood seeps out between the fingers. So that's what these lines are here. Again, here, so there's sparing where the fingers are. So in these kinds of cases, like if I was seeing this child, I might actually put my hand up to the child's face and just say, oh yeah. And then I would probably take a picture of the other side just to say, well, there's nothing over here. Maybe sadly there is, but it's classic in its presentation. Of course, any kind of eyelid bruising or sclera bruising is highly concerning, and may actually be an indication of even strangulation. Other concerning bruises, patterns that might be seen, classic for us, we see looped cords, belt buckles, coat hangers, spatulas. I guess I've seen many of these things that look like patterns. And then I go back to the detective and say, hey, maybe if you could go out to the scene and see something that might look like a cord or these kinds of things, and then that tries to help put the case together for them. Here's some resources. Again, I can send Michelle if you want, or whatever would be helpful, just the slides without the photos. And again, our office is always available. If we're not there, you'll get routed to the social work desk in the emergency room, and they are outstanding. So I would call us or them. Our website's got lots of information. There's a resource called we call it WASAFE, where if you wanted to know what training is happening or where in Yakima you could get a sexual assault exam, you could go onto that website. If nothing else out of everything today, please know that there's somebody on call 24/7 for child abuse cases. So please feel free to call, consult with us. Happy to talk to you. King County Sexual Assault Response Center, they are very involved and have lots of great resources. And then there's the Children's Justice Center of King County. That is another resource for folks. I think that's pretty much it. So there you go. Lots of slides in a short amount of time.
That's great. It was a great review. There's stuff I didn't think about, so that's really helpful.
Good.
A question that I have, Joanne, is, sometimes somebody comes into clinic and there's concerns, or somebody brings something up. What do we document in our charts? Because again, as you said, these are legal things. What things should we avoid, or should we just say, just for those purposes?
Yeah, that's a great question, Michelle. Thank you for bringing that up. So yes, clearly your notes can be subpoenaed. You can be subpoenaed. As far as documentation, I would strongly advise as near verbatim as possible. So if you say to the patient, tell me what brought you here today, and they say, well, I have this, whatever. And, the other thing that's really been bothering me is, I had this incident happen to me 6 months ago, I would write, and what I do write is, I ask the patient how come they're here, and they said da da da. And I guess my thing further to that would be, as long as it's not within that window of acuteness, certainly you can refer them to us for further support. And then if they have concerns about, STIs and those kinds of things, I don't know, if they're in ortho and this happens to come up, maybe back to their primary care. But again, documentation, Michelle, to your point, is really important in all of our cases, like in all the work we do. But as far as that's concerned, so I would just take that little side note one further and just, here's what the patient said, and put it in quotes if you could. So hopefully that makes sense. So
Great. No, that's good.
Yeah. I think that in general, probably, less is better, in the sense, you certainly don't want to just obviously ignore that. Not that anybody in this group would, or a provider would, but it might be, hey, thanks for telling me that. I can help you with that. Here's some resources, that type of thing. So. Other questions? I hope that was helpful. Again, been around for a long time, and I obviously have a passion about this work, even though I've done it for a long time, and always happy to talk to people and take call. And so you can always call me.
No, this is great to get the resources and just kind of a general review, which again is fantastic. So I will be, hopefully I'm recording it, but I never know if this is going to work, but I will record it and at least we'll have the voice. But if somebody wants, I know some people kind of stepped in and out, but we'll put it on the website as well. And then if you could bring me, send me the slides, the ones that you can send to me, I will get those out to everyone as well, to share.
Great. Sounds good, Michelle. Thanks so much for the invite, and thanks everybody for your time.
Okay. I think I do have a couple of slides left to share. I think, again, this was from last time. I just want to point out, I know I get a lot of ask about pharmacology packages. And so here's a website that does a lot of pharmacology CME so that people are aware of that. And then again, always look at Harborview and UW's Professional Development and Nursing Excellence website. They have a lot of kind of general classes. Like again, there's an ostomy fistula. You may not do ostomy fistula as your regular work, but I get some of those patients in clinic, and it's good to have a little bit of an understanding of what to do in an emergency setting. There's pain management refreshers. There's all kinds of different throughout the year. And you can go to their website and see this in a bigger font because it's pretty small. But yeah, I mean, they're for nursing, but I think a lot of these things, just for us to have knowledge about, as they're a great resource for us as well. And then again, our website has some links to a lot of CME websites that are very helpful, because we all have to get our CME in. And again, if you still want to spend a little bit of money, you can still do that. And so there's lots of resources to where you can spend your money on different things. Remember, you can sign up for a conference in October, use this year's money to pay for the conference, and then next year or next fiscal year, use your money to pay for the hotel and flight. We don't reimburse hotel and flight until after the conference has occurred, because you want to use those things. But registering for the conference can be done in this fiscal year's money for something in the next year. Now, if it's travel, it has to have for inpatient, it has to go to the CNO for signature and approval. And for outpatient, it has to go to Cassie Holman, who's the administrator. So not just your manager's signature can work. So if you're going to do that, you want to make sure that you're submitting in a timely manner so it can get done. Because you don't want to, well, you will eventually pay for it, but it could end up being in next year's money, and you don't want to lose this year's money. Any questions from anything today? I know I went through a lot of things fast. Again, you know how to get my email and call or text me. Happy to answer questions. All right, everyone, thanks for coming today. And again, if you have ideas for speakers, if you want to speak, happy to have you. So just reach out and we can do any presentation or length. If you just want to do just like a few minutes on a topic to let people know about something, that's welcome too. Our next brown bag, I think, is July 18th, I'm not sure, but I will be sending out the next fiscal year calendar invites soon so that you guys have those on your schedule. All righty, well, it was good seeing everybody, and I will be ending our brown bag on time.